Good morning to you all. I would like to thank Sri Lanka College of Microbiologists, Minister of Health Sri Lanka and WHO Sri Lanka for giving me this opportunity to present the presentation. Today we are going to talk about rational use of antibiotics in healthcare setup. So what is rational? Rational is appropriate or does the required job with minimal or no side effects with lowest cost. And irrational means inappropriate, does not do the required job, unacceptable side effects, and cost more than benefit. So what are the antibiotics? They are different to other drugs. How? Antibiotics act on targets in the bacterial cells, selectively toxic to the bacteria, not to the human, while no effective action on human cells. So it is a selective advantage. All the other drugs act on targets in human cells, and antibiotics, no useful action on human cells. So that this is the difference between other drugs and antibiotics. Apart from that, they are societal drugs. That means antibiotics have profound and somewhat persistent effect on the intestinal tract, destroying the microbiota, our gut microbiota, by reducing the number of beneficial commensals and increased availability of potentially harmful microorganisms. The longest duration of changes observed by some studies shown that ciprofloxacin can leave disturbance to the microbiota for 1 year, clindamycin for 2 years, and clarithromycin plus metronidazole for 4 years. And resistant genes passes very easily to other organisms also. So no other category of medicine demonstrates this property. Why rational use of antibiotics needed? All are toxic. No benefit unless there is an infection. They are expensive. Development of multi-drug resistant bacteria by using irrationally antibiotics. Because intrinsically resistant bacteria can emerge with the destruction of sensitive organisms, such as Enterococcus, Pseudomonas, Acinetobacter. And resistance can be acquired by some other organisms such as Klebsiella, MRSA, ESBL, multi-drug resistant TB, and cholera. So why do we discuss about rational use of antibiotics? Because irrational use of antibiotics is a major issue worldwide. How common is it? More than 60 of outpatients' prescriptions are irrational. And we see even inpatients are safe. Irrational antibiotic use leads to development of antibiotic resistance and antibiotics become useless. So this is one of the isolate from a lab. In the middle, the patient's pathogen, and on the either side, control. So it is a resistant bacterial isolate from a patient with urine infection. So this organism shows resistant to imipenem and meropenem, while odd sensitivity showing intermediate sensitivity to cefoperazone sulbactam. What is the cost of antibiotic resistance? Death due to treatment failure, because there are no antibiotics available when the organisms are resistant to all the antibiotics available, and disability, long hospital stay, and medical expense. How do we reduce antibiotic resistance? It can be done by reducing selective pressure exerted by the use of antibiotics. Sensible regulation of drugs, such as following guidelines, informed and cautious prescribing, having some restrictions on antibiotic usage, strict infection control practices, including hand washing. Antibiotic guidelines. It's like road traffic rules in our country because neither followed. So you can see. And we use antibiotic as we want as well. Any combination of antibiotics for simply because the patient is admitted to the ICU, for clean surgeries, for diagnosed dengue. So the results of both are same. It's death. Component of rational prescription. Appropriate indication. We have to have an infection, bacterial infection, to start antibiotics. Appropriate medicine, we have to choose whether it is the efficacy, safety, suitable to the patient with cost consideration. And appropriate dosage, route, dose, duration. Appropriate patient, whether there's any contraindication, whether the patient is allergic to some antibiotics, or whether the patient is a small baby, neonate, or whether the patient is pregnant, or whether the patient is having renal failure. And the correct dispensing, with appropriate instruction to the patient and carer, aiming to improve the compliance, explaining how to take. And prescription of antibiotic when it is really not necessary is one of the reasons for appearance of resistance, such as antibiotics taken during viral infections, taken for uninfected chronic wounds. We know antibiotics are precious substances, not many new antibiotics in the horizon. Prescribe when necessary only, avoiding viral infection always. Don't prescribe for patient's pressure, but explain to the patient, because some patients, they ask for antibiotics. So we have to be strong not to give antibiotics for if there's no indication for antibiotics. Common mistakes. Using antibiotic combination with overlapping spectrum of coverage, like meropenem with cloxacillin, meropenem with piperacillin tazobactam, meropenem with ticagrelin clavulanic, because all these cloxacillin, piperacillin, and ticagrelin clavulanic acid, whatever covered by these antibiotics are covered by meropenem. So there's no additional benefit apart from toxicity by giving these drugs together. Similarly, clindamycin and metronidazole, because both are for anaerobic cover. If you have started one, there's no point of adding the second one. Overlapping cover examples. You can see here the patient is on flucloxacillin, linezolid, teicoplanin, and levofloxacin. As you can see, if the patient is on linezolid, all the organisms covered by flucloxacillin and teicoplanin are covered by linezolid. So there's no point of having 3 drugs here, only will cause toxicity and, of course, the cost and side effects. Another one, you can see the combination meropenem and cefotaxime. When the meropenem is given, there's no point of giving cefotaxime. Again, because meropenem covers whatever covered by cefotaxime. Again, penicillin and meropenem, same thing. Prescribing wrong medicines for wrong disease. Treatment of shigellosis, enteric fever with gentamicin, because the gentamicin is not effective against shigellosis or enteric fever. Treatment of community-acquired pneumonia with ciprofloxacin, because most of the time community-acquired pneumonia is caused by Streptococcus pneumoniae. So ciprofloxacin is not effective against pneumonia. Food poisoning with antibiotics, diarrhea with antibiotics. In both occasions, antibiotics are not indicated, usually. Antibiotic no infection or indication. Sometimes just because the patient is admitted to the ICU, antibiotics are prescribed. And for clean surgeries and diagnosed dengue and the first few days of COVID-19. What do you try to treat in this situation? This is real examples. Can you see the patient's drugs? Patient is on acyclovir, antiviral, liposomal amphotericin, antifungal, colistin, the last resource 4 gram negatives, and doxycycline. So we need to see whether they are indicated. Just combining will not save a life. Here again, levofloxacin, clindamycin, acyclovir, meropenem, flucloxacillin. So what do you want to cover with these drugs are not clear. Another one, any rationale, I wonder, cefepexone sulbactam, acyclovir, liposomal amphotericin, linezolid, colistin, and doxycycline. Whatever available in Sri Lanka, the last resources are here, colistin and linezolid and liposomal amphotericin. So I wonder whether the child is having viral, fungal, and MRSA and multi-resistant gram-negative and atypical. So we need to think before starting antibiotics. Our time with antibiotics is running out. Always seek the advice of the healthcare professional before taking antibiotics. But if we are prescribing like that, what can we do? Antibiotic resistance. What can we do, healthcare workers? Prevent infection by ensuring your hands, instruments, and environment are clean. Keep your patient's vaccines up to date. If you think a patient might need antibiotic where possible, test to confirm, do the cultures, and find out which one you need to give. Only prescribe and dispense antibiotics when they are truly needed. Prescribe and dispense the right antibiotic at the right dose for the right duration. Very important. Prolonged surgical prophylaxis, another error being done. The duration of prophylactic antibiotic therapy should generally be limited to 1 dose. We can give repeat dose of the antibiotic when the operation is longer than the half-life of the antibiotic given. For beta-lactams, repeat dose should be given after 3 to 4 hours. Clindamycin should be repeated every 3 to 6 hours and vancomycin 6 to 12 hours. Prophylactic antimicrobial agents should be continued for not more than 24 hours or maximum 3 doses. But you may have seen patients on so-called prophylaxis for many, many days. One more error we do, that not trusting the microlab or over-reliance on the laboratory report. Not over-reliance means if we have culture reports similar to this one here, of course, Coagulase negative Staphylococcus from the blood, which can be a contamination where you don't need to treat. And if you suspect patient to have an infection, you can repeat the blood culture. Or treating colonizing flora like in urine catheterized patients, sputum, wound swab cultures, and even the dangerous one, not treating pathogens like positive blood cultures, sterile fluid cultures. Resistance first demonstrated in places where overuse. Resistant hospital pathogens, and then slowly it goes to the other units and ultimately to the community as well, which is really, really dangerous. When antibiotic resistant organisms develop, people can't be effectively treated. Patients remain ill for longer. Patients are at greater risk of dying. Epidemics are prolonged and hard to control. Others are greater risk of infection. So we can reduce antibiotic resistance by rational using of antibiotics. Although emergence of Resistance to antibiotics is a natural process. It is a natural process. It is inevitable, but we can slow it down. We can make it prolonged by using antibiotic rationally. With responsible antibiotic usage, we can slow down the emergence of resistance. Thank you for your attention.